Exocrine Pancreas, Anatomy, Physiology, Pathology, Question and Answer Resource. Welcome to today's podcast, where we discuss the main aspects of surgical management of the exocrine pancreas. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the surgical management of the exocrine pancreas. Pause the podcast after each question to attempt answer. Let's begin. Exocrine pancreas anatomy question. What is the average size, weight, and location of the pancreas in adults? Answer. The average adult pancreas weighs 100 grams, measures 14 to 20 centimeters in length, and is located in the retroperitoneum. Question. How is the pancreas anatomically divided? Answer. Anatomically, the pancreas is divided into 5 sections: the head, uncinate process, neck, body, and tail. Question. Where is the head of the pancreas situated relative to other anatomical structures? Answer. The head of the pancreas lies to the right of the midline, within the C-loop of the duodenum, and is located anterior to the inferior vena cava. Arterial blood supply. Question. What is the source of arterial blood supply to the pancreas? Answer. The pancreas receives blood from a complex network of arteries branching from the celiac trunk and the superior mesenteric artery. Question. Which artery primarily supplies the head of the pancreas and how are its branches distributed? Answer. The gastroduodenal artery primarily supplies the pancreatic head, with its anterior and posterior superior pancreatoduodenal branches supplying different aspects of the head. Question. How do the superior and inferior pancreatoduodenal arteries contribute to the arterial supply of the pancreas? Answer. The superior and inferior pancreatoduodenal arteries form arcades within the pancreaticoduodenal groove, with the inferior pancreaticoduodenal artery arising from the superior mesenteric artery and dividing into anterior and posterior branches. Question. Which artery supplies the body and tail of the pancreas? Answer. The splenic artery supplies blood to the body and tail of the pancreas. Question. What is the branching pattern of the splenic artery in relation to the pancreas? Answer. The splenic artery branches into the dorsal pancreatic artery, the inferior pancreatic artery, and the greater pancreatic artery, forming an anastomosing network around the pancreatic body and tail. Question. What is the role of the greater pancreatic artery in pancreatic blood supply? Answer. The greater pancreatic artery, a major branch of the splenic artery, penetrates the pancreas and provides branches parallel to the main pancreatic duct, forming anastomosis with other tributaries. Venous drainage. Question. How is venous drainage from the pancreas organized? Answer. Venous drainage occurs via the anterior and posterior pancreaticoduodenal veins, which then drain into the superior mesenteric vein. Question. How is the venous drainage of the pancreatic head specifically managed? Answer. The posterior superior pancreaticoduodenal vein drains into the superior mesenteric vein laterally at the superior border of the pancreas neck. The anterior superior pancreaticoduodenal vein drains into the right gastroepiploic vein before joining the superior mesenteric vein at the inferior border of the pancreas. The anterior and posterior inferior pancreaticoduodenal veins drain into the superior mesenteric vein along the inferior border of the uncinate process. Question. How are the body and tail of the pancreas drained venously? Answer. The body and tail of the pancreas are drained through the splenic venous system. Lymphatic drainage. Question. What are the primary lymphatic drainage pathways of the pancreas? Answer. The pancreas has 4 quadrants of primary lymphatic drainage. The left side drains to the splenic hilum or gastrosplenic omentum, while the right side drains to gastroduodenal and infrapancreatic lymph nodes. Question. What is the secondary lymphatic drainage pathway of the pancreas? Answer. Retropancreatic lymph nodes, located anterior to the aorta, receive drainage directly from pancreatic tissue or from the primary drainage pathways. Question. Where are small lymph nodes distributed in relation to pancreatic lymphatic drainage? Answer. Small lymph nodes are present along the lymphatic channels of the primary drainage pathways. Innervation. Question. What types of nervous system innervation does the pancreas receive? Answer. The pancreas receives innervation from both the sympathetic and parasympathetic nervous systems. Question. Describe the pathway for sympathetic innervation of the pancreas. Answer. Sympathetic nerve fibers originate from the thoracic spinal cord, synapse in the abdominal plexus, and their postganglionic fibers reach the pancreas via arteries. Question. How does parasympathetic innervation of the pancreas occur? Answer. Parasympathetic vagal efferent nerves terminate in pancreatic nodes, with postganglionic fibers extending to acinar cells, islets of Langerhans, and pancreatic ducts. Question. How is pain from pancreatic cancer managed pharmacologically? Answer. Local anesthetic is administered to alleviate pain from pancreatic cancer. Question. What procedure is performed to manage pancreatic pain during endoscopic ultrasound? Answer. Celiac node infiltration is performed during endoscopic ultrasound. Question. Which local anesthetic is commonly used for pain management in pancreatic procedures? Answer. Xylocaine is an example of a local anesthetic used for pain management. Embryology. Question. When does pancreatic development begin and when do the dorsal and ventral buds fuse? Answer. Pancreatic development begins at the 4th week of gestation, with the dorsal and ventral buds fusing around the 8th week. Question. From which embryonic tissue do the dorsal and ventral pancreatic buds originate, and what do they form? Answer. The dorsal and ventral buds arise from the primitive duodenal endoderm, giving rise to the exocrine and endocrine components of the pancreas. Question. What is the process of pancreatic bud fusion during embryonic development? Answer. The ventral bud, initially part of the hepatic diverticulum, rotates posteriorly and fuses with the dorsal bud, forming the mature pancreas. Question. Which transcription factors are essential for pancreas and acinar cell development? Answer. PDX1 is essential for pancreas development, while PTF1 is crucial for acinar cell formation. Question. Which signaling pathways are important for exocrine differentiation and other aspects of pancreatic development? Answer. Notch signaling is vital for exocrine differentiation, while transforming growth factor beta, hedgehog, and WNT pathways also play important roles. Question. What is the role of PDX1 and PTF1 in pancreas bud formation and differentiation? Answer. The initiation of pancreas bud formation and differentiation is dependent on the expression of PDX1 and PTF1. Pancreas divisum. Question. How do the dorsal and ventral pancreatic ducts normally develop during embryogenesis? Answer. The dorsal and ventral pancreatic ducts fuse during embryogenesis to form the main pancreatic duct, known as the duct of Wirsong, and the accessory pancreatic duct, known as the duct of Santorini. Question. What is pancreas divisum and how does it affect ductal drainage? Answer. Pancreas divisum is a congenital anomaly where the dorsal and ventral pancreatic ducts fail to fuse, resulting in two separate ducts draining into the duodenum. Question. What is the clinical significance of pancreas divisum? Answer. Pancreas divisum can lead to partial obstruction of pancreatic exocrine secretions, potentially causing pancreatitis in some cases. Annular pancreas. Question. What defines annular pancreas as a congenital abnormality? Answer. Annular pancreas is a congenital abnormality where pancreatic tissue surrounds the second part of the duodenum. Question. With which other congenital defects may annular pancreas be associated? Answer. Annular pancreas can be associated with Down syndrome, malrotation, intestinal atresia, and cardiac malformations. Question. What is the preferred treatment for annular pancreas and why? Answer. Surgical bypass through duodenojejunectomy is preferred over dividing the pancreatic tissue to avoid pancreatic fistula formation. Ectopic pancreas. Question. What is the definition of ectopic pancreas? Answer. Ectopic pancreas is pancreatic tissue located outside the pancreas. Question. Where is ectopic pancreatic tissue most commonly found? Answer. Ectopic pancreatic tissue is most commonly found in the stomach, duodenum, and mecal diverticulum. Question. What are the clinical implications of ectopic pancreas? Answer. Ectopic pancreas may cause bowel obstruction, bleeding, or ulceration, but resection is not necessary unless it is symptomatic. Physiology. Question. What are the main cellular components of the pancreas? Answer. The pancreas is composed primarily of acinar cells, 85%, islet cells, 2%, and extracellular matrix, 10%. Question. What are the functional roles of the pancreas? Answer. The pancreas functions as both an endocrine and exocrine gland. Question. What other structural components are present in the pancreas? Answer. The pancreas contains an epithelial duct system and blood vessels, which make up 3 to 4% of its composition. Major components of pancreatic juice. Question. What is the primary function of the exocrine pancreas? Answer. The exocrine pancreas provides enzymes necessary for digestion. Question. What is the role of acinar cells in the pancreas? Answer. Acinar cells synthesize and secrete digestive enzymes including trypsin, chymotrypsin, carboxypeptidase, and elastase. Question. How are pancreatic digestive enzymes activated? Answer. Enterokinase activates trypsin, which then activates other proenzymes required for protein digestion. Question. Which additional enzymes are produced by acinar cells? Answer. Acinar cells produce pancreatic amylase, lipase, colipase, cholesterol ester hydrolase, phospholipase A2, deoxyribonuclease, and ribonuclease. Question. What is the function of amylase in pancreatic juice? Answer. Amylase hydrolyzes polysaccharides into oligosaccharides, which are further digested by oligosaccharidases in the duodenum and jejunum. Question. What is the function of lipase in pancreatic juice? Answer. Lipase hydrolyzes fats into free fatty acids and 2-monoglycerides. Question. Why are pancreatic enzymes synthesized and stored as inactive forms? Answer. Pancreatic enzymes are synthesized and stored as inactive enzymes to prevent autodigestion of pancreatic tissue. Question. What is the role of pancreatic secretory trypsin inhibitor and which gene encodes it? Answer. Pancreatic secretory trypsin inhibitor, encoded by the serine protease inhibitor Casl type 1 gene, counteracts premature trypsinogen activation, thereby protecting acinar cells from autodigestion. Question. What is the clinical significance of mutations in the serine protease inhibitor Casl type 1 gene? Answer. Mutations in the serine protease inhibitor Casl type 1 gene are linked to chronic pancreatitis, particularly in children. Question. What is the primary function of water and electrolytes in pancreatic juice? Answer. Water and electrolytes dilute and deliver enzymes from acinar cells. Question. How do sodium, potassium, bicarbonate, and chloride concentrations in pancreatic juice compare to plasma? Answer. Sodium and potassium concentrations are similar to plasma, while bicarbonate and chloride concentrations vary depending on the phase of secretion. Question. How is bicarbonate secreted by pancreatic duct cells? Answer. Extracellular carbon dioxide diffuses into ductal cells, reacts with carbonic anhydrase to form bicarbonate and hydrogen ions, and bicarbonate is secreted into the lumen via an anion exchanger. Question. What is the role of the cystic fibrosis transmembrane conductance regulator in pancreatic bicarbonate secretion? Answer. The anion exchanger interacts with the cystic fibrosis transmembrane conductance regulator, and mutations in the cystic fibrosis transmembrane conductance regulator can impair bicarbonate secretion, potentially contributing to chronic pancreatitis. Question. Which hormone is the primary stimulator of pancreatic bicarbonate secretion, and how does cholecystokinin interact with it? Answer. Secretin is the primary stimulator of bicarbonate secretion, while cholecystokinin has a weaker effect and can synergize with secretin. Question. What mechanism is involved in hydrogen ion extrusion during bicarbonate secretion in ductal cells? Answer. Carbon dioxide hydration generates hydrogen ions, which are secreted by sodium-hydrogen exchangers in the basolateral membrane of ductal cells to maintain intracellular pH. Question. How does the sodium-potassium ADPase pump contribute to bicarbonate secretion? Answer. Sodium-potassium ADPase in the basolateral membrane of duct cells drive bicarbonate secretion by maintaining the sodium gradient for hydrogen ion extrusion. Question. What is the function of potassium channels in acinar cells? Answer. Potassium channels in the basolateral membrane of acinar cells maintain membrane potential for potassium recirculation driven by the sodium-potassium pump. Question. What is the purpose of bicarbonate secretion by pancreatic duct cells? Answer. Pancreatic duct cells secrete bicarbonate to neutralize stomach acid in the duodenum. Question. What is the optimal pH for pancreatic enzymes, and why is it important? Answer. Pancreatic enzymes function best at a neutral to slightly alkaline pH, which is important for their activity. Question. What are the optimal pH ranges for chymotrypsin, trypsin, amylase, and lipase? Answer. Chymotrypsin and trypsin have an optimal pH of 8 to 9, amylase has an optimal pH of 7, and lipase has an optimal pH of 7 to 9. Phases and regulation of pancreatic secretion. Question. What are the phases of pancreatic secretion? Answer. The phases of pancreatic secretion are cephalic, gastric, and intestinal, similar to those of stomach secretion. Question. What triggers the cephalic phase of pancreatic secretion? Answer. The cephalic phase is triggered by the sight, smell, or taste of food, stimulating the vagus nerve. Question. What is the effect of the cephalic phase on pancreatic juice production? Answer. Acetylcholine release induces acinar cell enzyme secretion, accounting for 20 to 25% of daily pancreatic juice. Question. What triggers the gastric phase of pancreatic secretion and how is it mediated? Answer. The gastric phase is triggered by gastric distension after food ingestion and is mediated by the vagal reflexes. Question. What is the contribution of the gastric phase to daily pancreatic juice production? Answer. The gastric phase accounts for 10% of daily pancreatic juice production. Question. How significant is the intestinal phase in pancreatic secretion? Answer. The intestinal phase accounts for 65 to 70% of total pancreatic juice secretion. Question. What role does secretin play in the intestinal phase? Answer. Secretin mediates water, bicarbonate, and electrolyte secretion into the duodenum in response to duodenal acidification. Question. What is the mechanism of secretin action in pancreatic duct cells? Answer. Secretin increases intracellular cyclic adenosine monophosphate, activating the bicarbonate chloride exchanger and other processes in pancreatic duct cells. Question. What triggers cholecystokinin secretion and what is its primary function? Answer. Lipid, protein, and carbohydrates in the duodenum trigger cholecystokinin release, which is the main mediator of pancreatic enzyme secretion. Question. How does cholecystokinin act to stimulate pancreatic enzyme release? Answer. Cholecystokinin acts through the bloodstream and local reflexes to stimulate enzyme release, relax the sphincter of Oddi, and potentiate the effects of secretin. Acute pancreatitis. Question. How has the incidence of acute pancreatitis changed in recent years? Answer. The incidence of acute pancreatitis has increased over the past 20 years, resulting in over 300,000 hospital admissions annually in the United States. Question. What is the severity and mortality rate of acute pancreatitis? Answer. Most cases of acute pancreatitis are mild, but 10 to 20% are severe, with mortality rates ranging from less than 1% in mild cases to 10 to 50% in severe cases, particularly those with multiple organ dysfunction syndrome. Question. How is mortality distributed in acute pancreatitis? Answer. Mortality is bimodal, with early mortality within the first 2 weeks, due to multiple organ dysfunction, and late mortality after 2 weeks, often caused by septic complications. Pathophysiology. Question. What is the mechanism underlying acute pancreatitis? Answer. Acute pancreatitis results from abnormal pancreatic enzyme activation inside acinar cells, leading to cell death and inflammation. Question. What is the early event in the pathogenesis of acute pancreatitis? Answer. The early event is colocalization of zymogen granules and lysosomes in acinar cells, leading to trypsin activation by cathepsin B. Question. What is the role of cathepsin B in acute pancreatitis? Answer. Activated trypsin induces organelle leakage, releasing cathepsin B into the cytosol, which then triggers apoptosis or necrosis in acinar cells. Question. What is the consequence of pancreatic enzyme activation in acute pancreatitis? Answer. Pancreatic enzyme activation triggers autodigestion of pancreatic tissue. Question. Which inflammatory mediators are released by acinar cells in acute pancreatitis? Answer. Acinar cells release pro-inflammatory cytokines such as tumor necrosis factor alpha, interleukin 1, interleukin 2, interleukin 6, and anti-inflammatory mediators including interleukin 10 and interleukin 1 receptor antagonist. Question. How is the inflammatory response propagated in acute pancreatitis? Answer. Cytokines recruit neutrophils and macrophages, leading to the release of additional inflammatory mediators and reactive oxygen metabolites. Question. What is the impact of the inflammatory response in acute pancreatitis? Answer. The inflammatory response increases vascular permeability, damages microcirculation, and can lead to pancreatic necrosis and hemorrhage. Question. How do inflammatory mediators aggravate pancreatic injury? Answer. Inflammatory mediators aggravate pancreatic injury by causing pancreatic enzyme activation. Question. What is the risk of infection in acute pancreatitis? Answer. Dead pancreatic tissue can become infected due to gut bacteria translocation, requiring antibiotics such as imipenem. Question. What is the systemic inflammatory response in acute pancreatitis? Answer. Acute pancreatitis can lead to a significant release of inflammatory mediators into the bloodstream. Question. What are the systemic complications of acute pancreatitis? Answer. The systemic inflammatory response can result in sepsis, renal failure, and acute lung injury. Question. How do systemic complications contribute to mortality in acute pancreatitis? Answer. Systemic complications contribute to the high mortality rate associated with acute pancreatitis. Risk factors. Question. What are the most common causes of acute pancreatitis? Answer. Gallstones and ethanol abuse account for 70 to 80% of acute pancreatitis cases. Question. What are common causes of acute pancreatitis in children? Answer. Abdominal blunt trauma and systemic diseases are common causes of acute pancreatitis in children. Question. What should be considered in the differential diagnosis for patients with rheumatic conditions presenting with pancreatitis? Answer. Autoimmune and drug-induced pancreatitis should be considered. Biliary or gallstone pancreatitis. Question. What is the most common cause of acute pancreatitis in Western countries? Answer. Gallstone pancreatitis is the most common cause of acute pancreatitis in Western countries, accounting for 40% of cases in the United States. Question. What is the incidence and demographic distribution of acute pancreatitis in patients with symptomatic gallstone disease? Answer. The incidence is 3 to 8%, and it is more frequent in females between 50 and 70 years of age. Question. What are the two main theories for pancreatic injury in gallstone pancreatitis? Answer. The obstructive theory suggests that increased intraductal pressure from pancreatic duct obstruction initiates pancreatitis, while the reflux theory proposes that bile salt reflux into the pancreas causes acinar cell necrosis. Alcohol-induced injury. Question. What is the prevalence and demographic profile of ethanol-induced acute pancreatitis? Answer. Ethanol-induced pancreatitis accounts for 35% of cases and is more common in males aged 30 to 45 years. Question. What are the risk factors for for ethanol-induced acute pancreatitis? Answer. Heavy alcohol consumption, smoking, and genetic predisposition are risk factors for ethanol-induced acute pancreatitis. Question. How does smoking affect the risk of alcohol-induced pancreatitis? Answer. Smokers have a 4.9 times higher relative risk of alcohol-induced pancreatitis compared to non-smokers. Question. What are the mechanisms of alcohol-induced pancreatic injury? Answer. Alcohol triggers pro-inflammatory pathways, causes inappropriate zymogen exocytosis, increases autophagy, and induces oxidative stress. Question. How does alcohol impact pancreatic cell repair and cell death? Answer. Alcohol activates pancreatic stellate cells, impairs pancreatic cell repair, and shifts cell death from apoptosis to necrosis. Question. Which molecular pathways are involved in alcohol-induced pancreatic injury? Answer. Alcohol upregulates nuclear factor kappa B, 2 more necrosis factor alpha, and interleukin 1, dysregulates cathepsin L and B, and decreases caspase 3 and 8 activity. Anatomic obstruction. Question. How can abnormal flow of pancreatic juice into the duodenum cause pancreatic injury? Answer. Abnormal flow of pancreatic juice into the duodenum can result in pancreatic injury. Question. What is the association between pancreas divisum and acute pancreatitis? Answer. Pancreas divisum, an anatomic variation, is associated with a 5 to 10% lifetime risk of acute pancreatitis due to relative outflow obstruction. Question. What other anatomic obstructions can be associated with acute pancreatitis? Answer. Infrequent anatomic obstructions such as Ascaris lumbricoides infection and annular pancreas can also be associated with acute pancreatitis. Endoscopic retrograde cholangiopancreatography induced pancreatitis. Question. What is the incidence of acute pancreatitis following endoscopic retrograde cholangiopancreatography? Answer. Acute pancreatitis occurs in up to 5% of patients after endoscopic retrograde cholangiopancreatography, and can be as high as 15% in high-risk patients. Question. What are the risk factors for endoscopic retrograde cholangiopancreatography induced acute pancreatitis? Answer. Risk factors include being female, young, having a history of endoscopic retrograde cholangiopancreatography induced pancreatitis, undergoing therapeutic procedures, multiple cannulation attempts, or sphincter of Oddi dysfunction. Question. How can the risk of endoscopic retrograde cholangiopancreatography induced acute pancreatitis be reduced? Answer. Endoscopic retrograde cholangiopancreatography should only be performed when necessary, and alternative diagnostic modalities such as magnetic resonance cholangiopancreatography should be considered. Question. What pharmacologic agent is commonly used to prevent endoscopic retrograde cholangiopancreatography induced acute pancreatitis? Answer. Indomethacin is the most commonly used pharmacologic agent for prevention. Question. What technique-related approach reduces the risk of post-endoscopic retrograde cholangiopancreatography pancreatitis? Answer. Using minimal pressure during endoscopic retrograde cholangiopancreatography can reduce the risk. Question. How can interventional prevention be achieved for post-endoscopic retrograde cholangiopancreatography pancreatitis? Answer. Pancreatic stents can be used to lower the risk of post-endoscopic retrograde cholangiopancreatography pancreatitis. Drug-induced pancreatitis. Question. What proportion of acute pancreatitis cases are caused by medications? Answer. Up to 2% of acute pancreatitis cases are caused by medications. Question. Which medications are commonly implicated in drug-induced acute pancreatitis? Answer. Sulfonamides, metronidazole, erythromycin, tetracyclines, and several other medications are commonly implicated. Question. Which other medications can cause acute pancreatitis? Answer. Didanosine, thiazides, furosemide, statins, azathioprine, 6-mercaptopurine, 5-aminosalicylic acid, sulfasalazine, valproic acid, and human immunodeficiency virus antiretroviral agents can also cause acute pancreatitis. Metabolic factors. Question. How does hypertriglyceridemia cause acute pancreatitis? Answer. Triglyceride levels exceeding 1,000 mg per deciliter, particularly over 2,000 mg per deciliter, can directly damage the pancreas, especially in individuals with type 1, 2, or 5 hyperlipidemia. Question. How does hypercalcemia contribute to the development of acute pancreatitis? Answer. Elevated calcium levels can activate trypsinogen, leading to ductal obstruction and pancreatitis, particularly in patients with primary hyperparathyroidism. Question. Which conditions are not typically associated with hypercalcemia-induced pancreatitis? Answer. Hypothyroidism, diabetes mellitus, and alcohol consumption typically do not cause hypercalcemia-induced pancreatitis. Miscellaneous conditions. Question. What are the traumatic causes of acute pancreatitis? Answer. Traumatic causes include blunt and penetrating abdominal trauma, prolonged intraoperative hypotension, and excessive pancreatic manipulation during abdominal surgery. Question. What is an iatrogenic cause of acute pancreatitis? Answer. Pancreatic ischemia after splenic artery embolization is an iatrogenic cause. Question. What are other rare causes of acute pancreatitis? Answer. Other rare causes include scorpion venom stings and perforated duodenal ulcers. Clinical manifestations. Question. What type of abdominal pain is characteristic of acute pancreatitis? Answer. Acute pancreatitis is characterized by constant epigastric or periumbilical pain radiating to the back, often accompanied by nausea or vomiting. Question. What are the symptoms of dehydration in acute pancreatitis? Answer. Symptoms include dehydration, poor skin turgor, tachycardia, hypotension, and dry mucous membranes. Question. What symptoms may indicate severe dehydration, especially in older patients? Answer. Mental status changes may occur in severely dehydrated and older patients. Question. What findings may be present on abdominal examination in acute pancreatitis? Answer. Abdominal examination ranges from normal or mild epigastric tenderness in mild cases to significant distension, rebound tenderness, and rigidity in severe cases. Question. What is the significance of flank and periumbilical ecchymosis in acute pancreatitis? Answer. Flank, Gray-Turner sign, and periumbilical, Cullen sign ecchymosis are rare but indicate retroperitoneal bleeding in severe pancreatitis. Question. When might jaundice and pleural effusion occur in acute pancreatitis? Answer. Jaundice may occur with cholelithiasis or pancreatic head edema. Pleural effusion, indicated by dullness to percussion and decreased breath sounds, can be a complication. Diagnosis question. What are the diagnostic criteria for acute pancreatitis? Answer. Diagnosis requires 2 out of 3 features: abdominal pain, elevated serum amylase or lipase, or imaging findings consistent with pancreatitis. Question. Why is lipase preferred over amylase for diagnosing acute pancreatitis? Answer. Lipase is a more sensitive and specific marker for acute pancreatitis, especially beyond the first 24 to 48 hours of symptom onset. Question. What are the limitations of amylase in diagnosing acute pancreatitis? Answer. Amylase levels can be elevated in various conditions, making it less specific for diagnosing acute pancreatitis. Question. What laboratory findings are commonly seen in acute pancreatitis? Answer. Common laboratory findings include hyperglycemia, leukocytosis, and elevated liver enzymes. Question. How does hypovolemia manifest in laboratory values for acute pancreatitis? Answer. Elevated hemoglobin and hematocrit suggest hypovolemia due to fluid leakage into the retroperitoneum. Question. What is the significance of elevated alanine aminotransferase levels in acute pancreatitis? Answer. Elevated alanine aminotransferase levels in the context of confirmed acute pancreatitis have a high positive predictive value for acute biliary pancreatitis. Imaging studies question. What is the role of imaging studies in acute pancreatitis? Answer. Imaging studies are not required for diagnosis but can be helpful in determining the need for intervention in severe cases or identifying the cause. Question. What is the value of abdominal radiographs in diagnosing acute pancreatitis? Answer. Abdominal radiographs are not useful for diagnosing pancreatitis but can help rule out other conditions such as perforated ulcer disease. Question. What nonspecific findings might be seen on imaging in acute pancreatitis? Answer. Nonspecific findings include air fluid levels, cutoff colon sign, pleural effusions, and widening of the duodenal C loop. Question. What limits the use of ultrasound in diagnosing acute pancreatitis? Answer. Ultrasound is limited by intra-abdominal fat and increased intestinal gas. Question. Why is ultrasound recommended in all patients with acute pancreatitis? Answer. Ultrasound is recommended due to its high sensitivity, 95%, in diagnosing gallstones. Question. How is biliary pancreatitis diagnosed using laboratory and imaging studies? Answer. Combined liver transaminase, pancreatic enzyme levels, and gallstones on ultrasound have 97% sensitivity and 100% specificity for biliary pancreatitis. Question. What is the best imaging modality for evaluating the pancreas in acute pancreatitis? Answer. Contrast-enhanced computed tomography, especially with a multi-detector computed tomography scanner, is the best modality. Question. When is computed tomography indicated in acute pancreatitis? Answer. Computed tomography is indicated for diagnostic uncertainty, confirming severity, lack of response to conservative treatment, or clinical deterioration. Question. Which contrast phase is most valuable for evaluating pancreatic parenchyma? Answer. The portal venous phase, 65 to 70 seconds after contrast injection, is most valuable for evaluating pancreatic parenchyma viability, peripancreatic inflammation, and the presence of free air or fluid collections. Question. What is the role of abdominal magnetic resonance imaging in acute pancreatitis? Answer. Abdominal magnetic resonance imaging is useful for evaluating necrosis, inflammation, and free fluid, but is limited by cost, availability, and patient condition. Question. What is the role of magnetic resonance cholangiopancreatography in acute pancreatitis? Answer. Magnetic resonance cholangiopancreatography is important for evaluating unexplained or recurrent pancreatitis, providing non-invasive visualization of biliary and pancreatic duct anatomy. Question. How is secretin-stimulated magnetic resonance cholangiopancreatography used in pancreatic evaluation? Answer. Secretin-stimulated magnetic resonance cholangiopancreatography is useful for difficult-to-view pancreatic ducts, helping to rule out conditions such as pancreas divisum, intraductal papillary mucinous neoplasm, or small tumors. Question. What is the role of endoscopic ultrasound in gallstone pancreatitis? Answer. Endoscopic ultrasound is crucial for evaluating persistent cholelithiasis in gallstone pancreatitis. Question. What advantages does endoscopic ultrasound have over routine endoscopic retrograde cholangiopancreatography in pancreatitis? Answer. Endoscopic ultrasound is sensitive for detecting cholelithiasis without worsening pancreatitis, unlike routine endoscopic retrograde cholangiopancreatography. Question. When is endoscopic retrograde cholangiopancreatography used in pancreatitis? Answer. Endoscopic retrograde cholangiopancreatography can be used selectively for therapeutic purposes after endoscopic ultrasound confirms persistent cholelithiasis. Assessment of severity of disease. Question. What is the purpose of the Ranson score in acute pancreatitis? Answer. The Ranson score predicts the severity of acute pancreatitis based on 11 parameters, with 3 or more positive criteria indicating severe pancreatitis. Question. What are the limitations of the Ranson score? Answer. The Ranson score has a low positive predictive value, 50%, and high negative predictive value, 90%, and is primarily used to rule out severe pancreatitis or predict mortality risk. Question. When are the parameters of the Ranson score assessed? Answer. 6 parameters are assessed 48 hours after admission, limiting its ability to predict severity at the time of admission. Question. What is the Apache 2 score and how is it used in acute pancreatitis? Answer. The Apache 2 score, based on age, health status, and 12 physiologic measurements, provides a general measure of disease severity. Question. What Apache 2 score indicates severe pancreatitis? Answer. A score of 8 or higher indicates severe pancreatitis. Question. What are the limitations of the Apache 2 score? Answer. The Apache 2 score is complex, not specific to acute pancreatitis, age-dependent, and requires 12 variables that are not always readily available. Question. What is the purpose of the Bishop score in acute pancreatitis? Answer. The Bishop score assesses the risk of death from acute pancreatitis. Question. What criteria are included in the Bishop score? Answer. The Bishop score includes elevated blood urea nitrogen, altered mental state, systemic inflammatory response syndrome, age over 60 years, and pleural effusion within 24 hours of admission. Question. What is the clinical significance of the Bishop score? Answer. The BISAP score correlates with mortality risk, organ failure, and pancreatic necrosis. Question. How is C-reactive protein used as an inflammatory marker in acute pancreatitis? Answer. C-reactive protein peaks 48 to 72 hours after pancreatitis onset and correlates with disease severity. Question. What C-reactive protein level indicates severe pancreatitis? Answer. A level of 150 mg per milliliter or higher indicates severe pancreatitis. Question. What are the limitations of C-reactive protein and other markers in acute pancreatitis? Answer. C-reactive protein cannot be used on admission. Other markers are costly and not widely available. Question. What is the purpose of the computed tomography severity index in pancreatitis? Answer. The computed tomography severity index correlates computed tomography findings with patient outcomes in pancreatitis. Question. Who developed the computed tomography severity index? Answer. The index was developed by Balthazar and Associates. Question. On what basis is the computed tomography severity index determined? Answer. The index is based on imaging characteristics. Question. Why do professional societies recommend the systemic inflammatory response syndrome scoring system in pancreatitis? Answer. Professional societies recommend systemic inflammatory response syndrome for its speed, cost-effectiveness, and reliability in predicting disease severity. Question. What are the mortality rates associated with persistent, transient, and absent systemic inflammatory response syndrome in pancreatitis? Answer. Persistent systemic inflammatory response syndrome is associated with 25% mortality, transient systemic inflammatory response syndrome with 8% mortality, and absence of systemic inflammatory response syndrome with 0% mortality. Question. What are the advantages of the systemic inflammatory response syndrome scoring system in pancreatitis? Answer. The systemic inflammatory response syndrome scoring system is fast, inexpensive, and reliable, and is an alternative to complex prognostic indices requiring imaging or unavailable at admission. Question. How is severe pancreatitis defined? Answer. Severe pancreatitis is defined by the presence of local pancreatic complications, necrosis, abscess, or pseudocyst, or any evidence of organ failure. Question. How is severity graded in pancreatitis? Answer. Severity is graded as mild, no organ dysfunction or local systemic complications, moderate, organ failure less than 48 hours and or local systemic complications, and severe, organ failure greater than 48 hours. Question. How does increased severity of pancreatitis relate to morbidity and mortality? Answer. Increased severity correlates with increased morbidity and mortality rates. Treatment. Question. What are the cornerstones of treatment for acute pancreatitis? Answer. The cornerstones of treatment are aggressive fluid resuscitation, early nutrition, and pain control. Question. What is the recommended fluid for resuscitation in acute pancreatitis? Answer. Isotonic crystalloid solution is used to restore tissue perfusion. Question. What is the role of early nutrition in acute pancreatitis? Answer. Early nutrition helps counteract catabolism and decrease infection rate. Question. Why is intravenous fluid replacement necessary in acute pancreatitis? Answer. Intravenous fluid replacement is essential for compensating reduced oral intake and losses from vomiting or third space fluid accumulation. Question. How does hypovolemia impact prognosis in acute pancreatitis? Answer. Hypovolemia is recognized as an unfavorable prognostic factor and requires treatment. Question. Which initial resuscitation fluid may be preferable in acute pancreatitis and why? Answer. Lactated Ringer solution may be preferable due to potential anti-inflammatory effects and reduced risk of systemic inflammatory response syndrome. Question. What evidence supports the use of lactated Ringer solution in acute pancreatitis? Answer. A meta-analysis cited by the American College of Gastroenterology Acute Pancreatitis Task Force on Quality Guideline supports its use. Question. What was the odds ratio for developing systemic inflammatory response syndrome with lactated Ringer solution compared to normal saline? Answer. The odds ratio was 0.38, 95% confidence interval, 0.15 to 0.98. Question. How should the rate of fluid administration be determined in acute pancreatitis? Answer. The rate should be individualized and adjusted based on age, comorbidities, vital signs, mental status, skin turgor, and urine output. Question. What is the goal of fluid administration in acute pancreatitis? Answer. The goal is to titrate fluid administration to specific measures of perfusion. Question. What did the Waterfall trial in 2022 reveal about aggressive fluid resuscitation? Answer. The Waterfall trial challenged the practice of aggressive fluid resuscitation in acute pancreatitis. Question. What was the design of the Waterfall trial? Answer. The Waterfall trial was an international, multi-center randomized controlled trial comparing aggressive and moderate fluid resuscitation with lactated Ringer solution in adults with acute pancreatitis. Question. What was the primary outcome measured in the Waterfall trial? Answer. The primary outcome was the development of moderately severe or severe pancreatitis during hospitalization. Question. What was the safety outcome in the Waterfall trial and what was its impact? Answer. Fluid overload was the safety outcome, and the study was terminated early due to a higher incidence in the aggressive treatment group. Question. What are the requirements for patients with acute pancreatitis regarding monitoring? Answer. Patients with acute pancreatitis require fluid resuscitation and continuous pulse oximetry. Question. How should hypoxemia be managed in acute pancreatitis? Answer. Supplementary oxygen should be administered to maintain arterial saturation above 95%. Question. What is the cause of hypoxemia in acute pancreatitis patients? Answer. Hypoxemia is a common systemic complication caused by acute lung injury. Question. What analgesics are commonly used for pain management in acute pancreatitis? Answer. Narcotics, particularly morphine, are commonly used for pain relief. Question. What physiological effect does morphine have in acute pancreatitis? Answer. Morphine can increase sphincter of body tone. Question. Is there evidence that narcotics negatively affect acute pancreatitis outcomes? Answer. There is no evidence suggesting that narcotics negatively affect acute pancreatitis outcomes. Question. What is the preferred method of nutritional support in acute pancreatitis? Answer. Enteral feeding is preferred over total parenteral nutrition for treating acute pancreatitis due to its benefits in reducing mortality, organ failure, and infections. Question. What are the mechanisms by which enteral nutrition improves outcomes in acute pancreatitis? Answer. Enteral nutrition replenishes calories calories, increases splanchnic blood flow, and stimulates intestinal motility, leading to improved outcomes. Question: when should enteral feeding be started in acute pancreatitis? Answer: enteral feeding should be started within 24 to 72 hours, with evidence suggesting immediate feeding is safe, feasible, and associated with reduced complications and shorter hospital stays. Question: what is the recommendation for nasonteral feeding in patients unable to tolerate oral intake? Answer: nasonteral feeding should be initiated within 72 hours if patients cannot tolerate oral intake. Question: what are the indications and risks of total parenteral nutrition in acute pancreatitis? Answer: total parenteral nutrition is an option for patients unable to undergo enteral feeding due to conditions such as paralytic ileus or obstruction, but it carries risks including mucosal atrophy, decreased intestinal blood flow, and increased risk of infections. Question: what complications are associated with total parenteral nutrition in acute pancreatitis? Answer: total parenteral nutrition is associated with increased risks of central line infections, metabolic complications such as hyperglycemia and electrolyte imbalance, and bacterial overgrowth in the small bowel. Question: are prophylactic antibiotics recommended in severe acute pancreatitis? Answer: prophylactic antibiotics are not recommended as they do not decrease surgical intervention, infected necrosis, or mortality. Question: when should antibiotics be administered in acute pancreatitis? Answer: antibiotics should only be administered if a pre-existing infection is present or imaging suggests infected peripancreatic fluid collections. Question: what adverse effects are associated with prophylactic antibiotic use in acute pancreatitis? Answer: prophylactic antibiotics are associated with infections by gram-positive cocci and candida. Special considerations. Question: is early endoscopic retrograde cholangiopancreatography recommended for routine management of acute biliary pancreatitis? Answer: early endoscopic retrograde cholangiopancreatography is not recommended for routine use in managing acute biliary pancreatitis, regardless of severity. Question: when is endoscopic retrograde cholangiopancreatography indicated in acute pancreatitis? Answer: endoscopic retrograde cholangiopancreatography is only indicated for patients with cholangitis or persistent bile duct obstruction confirmed by imaging. Question: what is a safe alternative for high-risk patients with acute pancreatitis who cannot undergo surgery? Answer: endoscopic retrograde cholangiopancreatography with sphincterotomy is a safe alternative for older patients with poor performance status or severe comorbidities who cannot undergo surgery. Question: when is laparoscopic cholecystectomy indicated in mild acute biliary pancreatitis? Answer: laparoscopic cholecystectomy is indicated for all patients with mild acute biliary pancreatitis, except for older patients and those with poor performance status. Question: what are the benefits of early cholecystectomy in acute pancreatitis? Answer: early cholecystectomy is a safe procedure that decreases recurrence of the disease when performed during the initial hospital admission. Question: what is the recommended treatment for severe pancreatitis before attempting laparoscopic cholecystectomy? Answer: conservative treatment is recommended for at least 6 weeks before attempting laparoscopic cholecystectomy to decrease morbidity, complications, sterile and infected peripancreatic fluid collections. Question: how are peripancreatic fluid collections classified? Answer: peripancreatic fluid collections are classified as acute, less than 4 weeks, or chronic, over 4 weeks, and either simple or complex. Question: what is the nature of acute peripancreatic fluid collections? Answer: acute peripancreatic fluid collections are simple in nature and become pseudocysts after 4 weeks. Question: how are fluid collections in necrotizing pancreatitis classified based on duration? Answer: in necrotizing pancreatitis, acute necrotic collection occurs before 4 weeks, and walled-off pancreatic necrosis occurs after 4 weeks. Question: how do fluid collections differ from pseudocysts and cystic neoplasias? Answer: fluid collections are not surrounded by epithelium or fibrotic capsule, unlike pseudocysts and cystic neoplasias. Question: what is the treatment approach for most fluid collections in acute pancreatitis? Answer: supportive care is the treatment approach, as most fluid collections are spontaneously reabsorbed. Question: how is infection diagnosed in peripancreatic fluid collections? Answer: infection diagnosis is challenging due to overlapping symptoms with acute pancreatitis, but gas within a fluid collection on imaging is diagnostic. Question: when may infection be suspected in fluid collections? Answer: acute decompensation or lack of improvement after 10 to 14 days may indicate infection. Question: what is the recommended method for diagnosing infection in peripancreatic fluid collections? Answer: computed tomography guided fluid sampling is recommended for suspected infection. Question: what is the treatment for infected fluid collections? Answer: drainage, percutaneous or endoscopic, and intravenous antibiotics are necessary if infection is confirmed. Pancreatic necrosis and infected necrosis. Question: how is pancreatic necrosis defined and identified? Answer: pancreatic necrosis is defined as the presence of non-viable pancreatic tissue, appearing as low-density areas on computed tomography scans. Question: what is the most reliable method for diagnosing pancreatic necrosis? Answer: contrast-enhanced computed tomography scan is the most reliable method, showing low attenuation, 40 to 50 Hounsfield units, compared to normal pancreatic tissue, 100 to 150 Hounsfield units. Question: why is it important to identify and treat pancreatic necrosis? Answer: pancreatic necrosis is associated with multi-organ failure and increased mortality in acute pancreatitis. Question: how is the risk of infection in acute necrotic collection related to the extent of necrosis? Answer: the risk of infection is directly related to the amount of pancreatic necrosis. Question: what are the infection rates based on the size of necrosis? Answer: the infection rate is 22% for less than 30% necrosis, 37% for 30 to 50% necrosis, and 46% for more than 70% necrosis. Question: which bacteria are commonly involved in bacterial translocation during infected necrosis? Answer: bacterial translocation usually involves enteric flora such as gram-negative rods and Enterococcus species. Question: what clinical features raise suspicion for infected necrosis? Answer: prolonged fever, elevated white blood cell count, progressive clinical deterioration, sepsis, systemic inflammatory response syndrome, or organ failure raise suspicion for infected necrosis. Question: how is diagnosis of infected necrosis confirmed? Answer: Answer. Diagnosis is confirmed by gas within pancreatic necrosis on computed tomography scan or positive gram stain culture from fine needle aspiration. Question. What is the prevalence of infected necrosis in patients with persistent unwellness despite negative preoperative cultures? Answer. Despite negative preoperative cultures, 42% of patients with persistent unwellness may have infected necrosis. Question. What are the indications for intervention in pancreatic necrosis? Answer. Indications include persistent pain, failure to improve with conservative management, or symptomatic biliary or enteric obstruction. Question. When should intervention for necrosis be delayed? Answer. Intervention should be delayed to allow for walled-off necrosis development, if possible. Question. When is intervention clearly indicated in infected necrosis? Answer. Intervention is clearly indicated for infected necrosis, but even then should be delayed as much as possible to allow for walled-off necrosis. Question. What is the first-line antibiotic treatment for infected pancreatic necrosis? Answer. Intravenous carbapenems are the first-line treatment due to their penetration and broad spectrum. Alternatives include quinolones, metronidazole, third-generation cephalosporins, and piperacillin. Question. What surgical treatment was historically used for infected necrosis, and what are its risks? Answer. Historically, open necrosectomy was used, but it carries a high mortality rate, 25 to 30%, due to severity and complications. Question. What minimally invasive techniques are used as alternatives to open necrosectomy? Answer. Percutaneous, endoscopic, and laparoscopic techniques with anterior or retroperitoneal approaches are used as alternatives to reduce morbidity and mortality. Question. What were the findings of the randomized trial comparing open necrosectomy with the step-up approach? Answer. The step-up approach, involving percutaneous drainage followed by minimally invasive video-assisted retroperitoneal debridement, showed better long-term outcomes, including lower mortality and fewer complications, compared to early open necrosectomy. Question. What are the advantages of endoscopic management compared to minimally invasive surgical approaches in infected necrosis? Answer. Endoscopic management resulted in fewer pancreatic fistulae, shorter hospital stays, and lower costs compared to minimally invasive surgical approaches, although not superior in terms of mortality. Question. What is the current preferred approach for infected necrotizing pancreatitis? Answer. Recent findings favor antibiotics alone with delayed drainage over the previous standard of combining antibiotics with immediate drainage. Question. What did the Pointer trial find regarding immediate versus delayed drainage? Answer. The Pointer trial found no difference in complications or mortality between immediate and delayed drainage for infected necrotizing pancreatitis. Question. How did intervention rates differ between immediate and delayed drainage groups? Answer. The immediate drainage group had an average of 4.4 interventions, while the delayed drainage group had 2.6 interventions. Question. What percentage of patients in the delayed drainage group avoided drainage entirely, and what was the impact on hospital stay? Answer. 37% of patients in the delayed drainage group avoided drainage entirely, with a 15% shorter hospital stay. Question. What is the preferred initial approach for drainage in infected necrosis? Answer. Endoscopic drainage with a large bore stent and possible endoscopic debridement, with or without percutaneous drainage, is the preferred initial approach. Question. What is the next step if endoscopic and or percutaneous management fails? Answer. Minimally invasive surgery is usually more straightforward and effective if endoscopic and or percutaneous management fails. Question. What is essential for positive outcomes in managing infected necrosis? Answer. Physiologic and nutritional support is crucial for a positive outcome, and patients should be managed at high-volume centers with multidisciplinary conferences. Pancreatic pseudocysts. Question. What is the prevalence of pancreatic pseudocysts following acute pancreatitis? Answer. Pancreatic pseudocysts occur in 5 to 15% of patients with peripancreatic fluid collections after acute pancreatitis. Question. What is the composition of the capsule in a pancreatic pseudocyst? Answer. The capsule is made of collagen and granulation tissue and is not lined by epithelium. Question. How long does it typically take for a fibrotic reaction to form a pancreatic pseudocyst? Answer. The fibrotic reaction that forms the pseudocyst typically takes at least 4 to 8 weeks to develop. Question. What symptoms are experienced by patients with pancreatic pseudocysts? Answer. Up to 50% of patients experience symptoms such as persistent pain, early satiety, nausea, weight loss, and elevated pancreatic enzyme levels. Question. How is the diagnosis of pancreatic pseudocyst confirmed? Answer. Computed tomography or magnetic resonance imaging scans are used to confirm the diagnosis, while endoscopic ultrasound with fine needle aspiration is indicated when the diagnosis is unclear. Question. What are the biochemical characteristics of pancreatic pseudocysts? Answer. Pancreatic pseudocysts are characterized by high amylase levels, absence of mucin, and low carcinoembryonic antigen levels. Question. What is the recommended approach for asymptomatic patients with pancreatic pseudocysts? Answer. Observation is recommended, as spontaneous regression occurs in up to 70% of cases, especially for pseudocysts smaller than 4 centimeters in the tail without pancreatic duct obstruction. Question. When is invasive therapy indicated for pancreatic pseudocysts? Answer. Invasive therapy is indicated for symptomatic patients or when differentiation between cystic neoplasm and pseudocyst is unclear. Question. What are the criteria for endoscopic drainage of pancreatic pseudocysts? Answer. Endoscopic drainage is safe and effective for pseudocysts in close contact with the stomach or duodenum, with transpapillary drainage considered for those communicating with the main pancreatic duct. Question. When is surgical drainage indicated for pancreatic pseudocysts? Answer. Surgical drainage is indicated for patients not treatable with endoscopic techniques due to anatomy or failed endoscopic treatment. Question. How is definitive treatment chosen based on the location of a pseudocyst? Answer. Cysts near the stomach are treated with cystogastrostomy, involving an anterior gastrostomy. Question. What surgical drainage techniques are used for pancreatic pseudocysts? Answer. Drainage through the stomach, cystoduodenostomy for pseudocysts near the duodenum, and Roux-en-Y cystojejunostomy for pseudocysts not in contact with the stomach or duodenum. Question. What is the success rate of surgical drainage for pancreatic pseudocysts? Answer. Immediate cyst drainage is achieved in over 90% of cases. Question. What is the recurrence rate of pseudocyst formation after drainage? Answer. Recurrence may occur in up to 12% of cases during long-term follow-up. Question. What complications can arise from pancreatic pseudocysts? Answer. Complications include bleeding, pancreaticopleural fistula, bile duct and duodenal obstruction, rupture, and infection. Question. When is percutaneous drainage indicated for pancreatic pseudocysts? Answer. Percutaneous drainage is indicated only for septic patients with pseudocyst infection. Question. Why is percutaneous drainage limited in pancreatic pseudocysts? Answer. Because there is a high incidence of external fistula formation. That's it. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.